I've been very lucky and things have gone exactly according to plan. Do I regret spending, still working 12 hours a day? No, I don't think so. I think what I would say to myself at 30 is don't worry. We spend a lot of time worrying about stuff, most of it which never happens, as Tom Petty said.
Welcome to the DIEP End, a plastic surgery podcast where we explore the people and ideas shaping the future of surgery. Today, we're joined by Dr. David Hidalgo, an internationally acclaimed plastic surgeon known for pioneering the fibula free flap technique during his tenure as Chief of Plastic Surgery at Memorial Sloan Kettering. Dr. Hidalgo's innovations help redefine possibilities in reconstructive microsurgery, offering patients functional restoration combined with refined aesthetics. In the second chapter of his impressive career, Dr. Hidalgo shifted his focus to aesthetic surgery in New York City, where his meticulous approach and artistic eye have earned him a reputation for excellence in facial rejuvenation, rhinoplasty, and breast surgery. In this conversation, we'll dive into how Dr. Hidalgo successfully navigated these career transitions, his insights into blending surgical precision with artistic creativity, and the principles that have guided him to sustained excellence. Let's dive in.
Tonight, we're on the DIEP End again. I'm joined by my co-host, Hank, and we're here with Dr. David Hidalgo from New York, who is an inspiration to many plastic surgeons, including myself, because I was a fellow at Memorial Sloan Kettering, I think 2022 to 2023. I can't remember, 2021 to 2022. I can't believe I can't remember, but with Dr. Marara and the whole team there, and the name Dr. Hidalgo came up numerous times, just a leader in reconstructive microsurgery to now a leader in cosmetic and private practice. And so we look forward to hearing a little bit about that. But one of the things we're usually interested in starting off is a little bit about your upbringing. And what do you think kind of you can look back on your childhood or perhaps your upbringing and say, this had an impact or molded me to who I am today?
Well, thank you, Saïd and Hank, for the invitation. It's great to be with you guys, talk about some of my favorite topics. But as far as your first question, when I grew up, I was a solitary creature. I had a couple of older brothers. I was pretty much on my own. So the types of things that I would do to amuse myself were put model airplanes together. And you know what? Today everybody's on their phone, but things like that is where you start to learn about precision and perfection, because if you don't get the glue just right and it goes all over the place and makes a mess, it's frustrating. So these little things at an early age, you never know where they're going to lead, but they were an interesting and I think a foundational instrument in terms of getting going. So I think making things is what I did as a child. Besides that, drawing. So we moved around a lot, so I didn't have a lot of friends, long-term friends. So I was always, again, sort of solitary and doing a lot of drawings. And again, that would turn out to help me along the way as well. So, it was a good childhood, but I got some basic tools during that period.
That's really neat. Yeah, it's always fun to hear about these like little hobbies outside of school. So what would you say growing up outside of school? What do you think, what were some of your passions outside of like school and education?
Well, I wasn't, I got to tell you, I wasn't much of an athlete. So I tended towards doing things like drawing. As a side hobby, it's to this day, I got interested in cars. So I tinker around with vintage cars, even on my off time.
Yeah, I'm a big car guy. I love cars too. And so what do you think, at what point would you say you started to develop a passion or interest in medicine and plastic surgery?
Well, I think I became interested in medicine in high school and in college. I was torn between art and medicine, but, art seemed very, unconventional, and there was no clear pathway to getting where you want to go. So I went with the medicine side. And then when I was in medical school, I read this book, The Making of a Surgeon, about a general surgeon at Bellevue Hospital, and it was just wild, the stories there. And I said, wow, I want to go to a place like that. And that's where I matched, and I went to NYU. And the thing that turned me on at first was cardiac surgery. Like probably most of us, so glamorous and, life and death and very interesting. It was still evolving at the time. And so that was my track. I was going to be a cardiac surgeon. And then once I lived that life for a bit, and as a resident, you got to be a junior fellow for 3 months, and you lived in the ICU. And, and even as a second year resident, they would let us participate in the cases. I was doing some proximal vessels on the bypass cases. And you know what? It was a thrill, but then it was like, is that it? Is that all there is to it? And there was only 3 or 4 operations. And then I was in the recovery room one night, and I looked over and I saw this trauma patient that it looked like the wrong foot on the wrong side of the body. And what I found out is that this was a patient that got run over by a subway train, and their legs were obliquely amputated. So they had one good proximal and one good distal leg. And the microsurgeons put the good distal part on the good proximal part, so the patient had at least one leg. And I thought that was, it just blew my mind. And I said, wow, what kind of surgery is this? And then I got, hooked into the microsurgery guys there, Bill Shaw. And then I started saying, you know what, I want to be a plastic surgeon. And that's how it all came about.
Yeah, you're one of many who have mentioned cardiac surgery. It's so funny what the overlap is. And it's perhaps that cardiac surgery is so technical, putting vessels together, reconstruction or whatnot. But I feel like every other guest mentions an early interest in cardiac surgery.
Yeah, it was a Wild West and very glamorous and challenging.
Yeah. So you trained and practiced at a time when microsurgery was really evolving, and I'm always curious to think about what it was back then. What was that like, being kind of at the forefront of all of that?
Well, the other part of it was that we were at Bellevue Hospital, which, it's sort of like a clinical laboratory, because you get a lot of leeway from the attendings. There's good oversight, don't get me wrong, but it's a place where you can see opportunities to do things and to try techniques when the one that you're using is not so great. So it was a phenomenal time because microsurgery, as you said, just started, and all these flaps were being described. And as a resident, I got involved in writing a book with Bill Shaw that, by the way, took 7 years to finish. But that's another story. But we did the anatomy of every flap. And what we would do is we would study the anatomy, do it in the cadaver lab, and then we would find a clinical situation. We would find a clinical situation where that flap would apply. And so we pioneered in Bellevue a lot of the different flaps, like the deltoid flap, lateral arm flap. These are of historic interest now. Nobody uses them anymore. But it was amazing. And, Bill Shaw was the type of guy who said, okay, you know the anatomy, you know how to do it. Where's the case? Let's review the case. And then we would do it. So, we did just about every flap that we could come up with. We did free jejunums. We did bone flaps, fibulas. It was great. So it was a unique period. It was a great opportunity, and we all took advantage of it.
And then speaking of all of that, you were chief of plastic surgery at Memorial Sloan Kettering and pioneered the fibula flap for head and neck reconstruction. That's partly what we were talking about last night. Can you walk us through how that kind of technique came about?
Well, it was a perfect confluence of opportunity and training, because from the NYU program, when you finish there, you feel like you could do anything. And when I went to Memorial, they were desperate for a microsurgeon. They didn't have anybody. And so I was welcomed with open arms. And what happened is we started doing a lot of ilium mandibles. And, when I was a resident, I said, the one thing I never want to do is ilium free flaps for mandible. And there I was doing a whole bunch of them. And you really saw the shortcomings. It wasn't a great bone. It wasn't a great skin island. And so at the same time, we were doing fibulas for osteosarcomas of the humerus and other long bones. And so, one day it just clicked. We had something that worked, but didn't work very well. And we knew how to do fibulas. We hadn't used it for that application, but like most things, nothing's totally revolutionary. The things evolve. It's just one step further than where we had been. And so, one day the head and neck surgeons were very receptive. And I said, look, I think the flap we're using is not great. I think this one has a prospect of being better. And, it was in a day where you didn't have IRBs and no one was looking over your shoulder. You had the support of everyone. You had institutional support in terms of the resources that you needed. And so one day we did it. And it was successful right off the bat. It worked well. We had to figure out the skin island situation, which subsequently became, very straightforward and reliable. But that's the way it started.
I know we kind of skipped ahead a little bit, but I'm so curious, how intricate were those airplanes? Like, was it how many seats, individual seats did you have to put together? Was it specific airline types? I'm curious
No,
because I know that can be like a whole thing.
But no, they were, these were companies that made, models of every World War II or, Korean War, or whatever airplane. And it was just basically the outside. You could paint them. You could get very, very professional with them. And they were great exercises. And so, it was very helpful.
That's a great question, Hank. Hank, were you interested in
I was
that
just
too?
so curious. Well, just because I can imagine it would get very intricate, and especially I've seen your artwork and everything and how intricate that is. I can see where your artistic eye came from.
It certainly helps, no question.
So looking back on the oncologic reconstruction, how far have we come since the 90s? And is there anything that you wish was different in today's approach?
Well, Saeed, one of the reasons I transitioned away from reconstruction is because I didn't have any more big ideas, and I couldn't see where they're going to come from. And I would say, 20 plus years down the road, there certainly hasn't been anything revolutionary. What we've done is we've refined a lot of things like the DIEP flaps, which are programs named after, and other things, and breast reconstruction with implants and expanders. Everything's become refined. So I think it's going along step by step. The funny thing is, we're blind to the next thing because we just can't see it. But there may be something around the corner that somebody else is going to invent, is going to move us forward by leaps and bounds. But I think the progress has been great. The patients have really been the benefit of things like, skin sparing and then subsequently nipple sparing mastectomies with reconstruction. I mean, that's just been a game changer. So in the head and neck area, I don't think things have really gone a lot further. We have those CAD CAM things to help you cut the bone, but I think that's just, in my humble opinion, I think we're just trying to dumb down the operation so pretty much anybody can do it. I think the real shaping of the bone is, again, it's an artistic process, and back in the day when we were developing this, we needed some guidelines to get the shape right. So we took a Panorex and we took a CT scan cut through the mandible below the tooth roots and blew it up 1-to-1, and we made acrylic templates from those two things. So we had a side view and a bottom view, and that's what we used in the OR to shape the grafts. And that worked out great, and I think we also made models and tried to do it with that, 3D models of mandibles, but that didn't work as well. So the templates solved the problem, and then subsequently implants were placed now immediately. We used to do them delayed, so things have moved along pretty well. But back in the day, we kind of had it figured out, and I don't think there's been a lot of evolution since then in that particular application.
Yeah. So what if you had to pinpoint one thing you miss most about Memorial Sloan Kettering, what would it be? The cafeteria, the main lobby?
No, you know what? I'll tell you what it is. It's the camaraderie among the surgeons. We had this floor that was just all operating rooms, and you go from room to room, visit the thoracic surgeons, or at the end of the day, they'd create this massive hole and come see you at 4 o'clock and ask you to fix it. So it was the camaraderie, and that was it was precious, and it was amazing, and I think that's the thing that's gone today. As I talk to my colleagues there now, it's become much more corporate. And back in the day, the surgeons ruled because actually we were the only ones curing cancer, if you will. And today it's much more corporate, and everybody's in their place. So I'm glad I'm not there today, but back in the day it was amazing.
Yeah. So, and then you talked about what kind of inspired your leap to the outside world and to where you are today. Is there anything from a reconstructive mindset that you think helped you navigate the jump to, because you basically jumped into one of the most competitive cosmetic markets probably in the country, arguably probably the most, and climbed up to the top pretty quickly. What do you think kind of helped make that leap and for you to excel?
Well, I think, applying a lot of the things you learn as a reconstructive surgeon. And I would say, as an aside, that, if you're starting a career, it's great to start in an institution because you get a caseload right away. Mm-hmm. You've got things to do. You're not just hanging out a shingle and waiting for the phone to ring. On the other hand, in my own case, I don't think it's a good place to end up at the end of your career. I think it's better to have a little bit more control. And so for me, in terms of making that transition, as far as the technical part, the training I had at NYU, we had all the greats there in every field. Aston and Baker were our cosmetic guys. Bill Shaw was our micro guy. We had Joe McCarthy, and on and on and on. So I was exposed to all of these guys, and I didn't want to at the end of the day, I didn't want to get pigeonholed in one thing. I liked all aspects of plastic surgery, so I wanted to be able to do all of it. And I went to Memorial because it was a great opportunity, and I would never change that. We got so much done, but I didn't want to end up there. And so from the earliest time, I was planning a transition. I thought it would take 5 years. It took 14. But, in terms of the skill set, what I learned from reconstruction, I think the two biggest things are persistence and perfection, or perfectionism. And by persistence, I mean, when you're doing these free flaps and it's 3 a.m. and that's not right, you take it apart, you do it again. The clock doesn't mean anything. And so you learn that the clock is not important, and from that, you approach your cosmetic cases that way. You don't want to bang it out in 2 hours. If it's not right, you redo it. And if it takes 3 hours or 4, that's fine. So I got that from reconstruction. And also the fact that, just like an anastomosis has to be perfect, so does a lower eyelid or a rhinoplasty, even more so than probably a microanastomosis. So yeah, I carried those two traits with me. But in terms of making the actual transition, I did it gradually. And what I did is the folks at Memorial were so supportive. I said to them, look, I want to do breast reductions and things. And people aren't going to come to the hospital for that because it's a cancer hospital. I want an office on Park Avenue and that I can do those things. So I bought an office. They helped me build it out with an OR so that for a time I was at Sloan. And then a couple days a week, I was in the office. And then what happens is, you watch your caseload. So originally it's reconstruction cases like this, and your aesthetic cases are like that. But at a certain point, they cross. And for me, that happened at around the 14-year mark. And so I said, you know what, this is it. This is time to take the leap. I took the leap. And from then on, I mean, the cosmetic cases went like that. I was very lucky. But the transition was handled in that way. And it was basically the fact that the driver for me was that I wanted to do all aspects of plastic surgery. And I'm so happy that I did that.
Now that you're in private practice and you've been successful on both ends of the spectrum, what are some of the if someone else is in your position, they're at the height of their game in the reconstructive realm, is there any advice that you could give them to have the courage to like take on a new risk?
Yeah. Well, it depends on how comfortable you are with risk. It depends on what your overhead is. Do you have 3 kids in a family? Can you take that chance? For me, I was lucky because my wife worked. We had one son, and he was pretty much grown up. So I was able to take that risk. Not everybody can, and even if you do, it's daunting. In my age, when I got started, you built your reputation by getting written up in one of the Condé Nast magazines. Today it's social media. It's a whole different game. So reputation's important, but it's hard to transition from a reconstructive reputation to an aesthetic surgeon reputation. And I think also today it's harder because our residents coming out of the programs, I don't think they get trained as well in aesthetic surgery. I was lucky back in the day because we had clinics, and we would do plastic surgery for free for patients who would come over with oversight by the attendings. And so we got a lot of experience. My last year, I did like 50 rhinoplasties. So, if you're going to make that transition, you got to be comfortable that you can do the work, that you're willing to take the risk, that you have the wherewithal to set up an operation. But for me, the pathway, and I think this would work for others as well, is to do it gradually. Get an office outside, get an OR. You don't even have to own it. You can use a surgery center and just start putting yourself out there and putting energy in your day into building that. So you can do it. It can be done, but it's a challenge.
Was there any resentment or feelings from people at MSK that you were leaving and moving on to this next step, or were you worried about that? Did you hear, were they supportive?
Well, you know what? Again, we had the surgeons had such great camaraderie. The head and neck surgeon, Jayden Shaw, probably the most famous head and neck surgeon in the entire planet,
he's still
going at it 50 years into it. He was sad. He says, David, can't you stay longer? But for me, it was the moment. And the chief of surgery, who was so supportive, Murray Brennan, another genius and one of the 2 smartest people I know, the other being my wife, he was okay with it. And there were no hard feelings. Everybody wanted the best for everyone. And by the way, I set them up. I had Peter Cordero, I had Joe Disa. I knew that the work wasn't going to stop and that it was only going to grow. We had 2 attendings. I think now they got a dozen. So I knew that the machine was going to keep going. I knew that the tools that I added to them would continue to do well, and Joe and Peter were going to do great. So it was a no-brainer for me, and everybody took it well, and they were very gracious.
Yeah, it's well, Disa's still there, Cordero's still there. I had the opportunity to operate with both of them. They're both wonderful.
Yeah.
Hank and I have both, reviewed your passion for art prior to all of this and know you have a deep appreciation for it. Can you tell us a little bit about that, where you think that comes from and how you think that helps you?
Yeah, but as I mentioned, it started at the earliest time. I would draw pictures of, again, airplanes and things. And as I went through high school, I painted. In college, I did a fine arts double major with bio pre-med. So it was always there, and again, I wasn't committed enough to take the leap, and I'm kind of glad I didn't, because you can be a great artist, but if you're not doing the right thing at the right time, you don't have the right representation, it's a life that, in a sense, can be wasted. So I didn't want to do that, but it always circled back, and as time has gone on, I would, I don't play golf, I don't ski, so I got a lot of time, and I don't have a girlfriend, so I got a lot of time. So my wife would shoot me. So I had time to to work on the art and develop it. I painted it first, and I found out I wasn't very good at that, and so I focused on the charcoal drawings, which is what I do now, and it's on the website and Instagram and whatnot. So, those are like microsurgery. I mean, they take a ton of patience. They take forever to do. It takes me a year to do one of those. But, I must say that I'm not aware of how it's helped me as a plastic surgeon, but it undoubtedly has. I spent like all of us, during the day, we spend our lives seeing things and changing things. It's a visual game that we're playing. But I also do that at night in a different way. So it's all one big thing where it's all about aesthetics 24/7. And I think it helps plastic surgery. I mean, I think I take for granted some of that because if I'm doing a case like a breast case, you see people, they like draw all over the body. They draw the sternal notch, and all these lines everywhere. And I think you do that when you don't have you're not comfortable with the gestalt of how something looks and what you're going to do. You have to kind of lay it out and measure and this and that. And that works. And in a workmanlike fashion, you can get good results. But there's another dimension where it's all about your eye and how you see. And you take all of these things into consideration, but you don't have to draw them all on the patient. And that's not a bad thing, but I just think when you overdo it, you're relying on that too much. So I'm getting a little afield here, but art has been very helpful in terms of how you see and how you plan things out.
When it's funny because I was just thinking to myself how much I loved art growing up and how little time I have for it now. How do you even make time to do it now?
Well, it's discipline like anything else. I'll do like tonight. I'll go home. I'll do an hour and a half of drawing, and I'll try to do at least 6 hours during the week, and I'll do on one drawing, and then we go someplace else on the weekend. And out there, I have another drawing. And I'll do 10 hours on the weekend, and you just do it. It's like a writer. If you're going to write a book, you got to write a little bit each day. I mean, I'm not a writer. I have no idea, but you got to write a little bit each day. And, you just don't sit down one weekend and write a whole book. And it's like building a house too. With these drawings, you do a little bit and week in, week out, not much is happening, but 3 months later you say, wow, this is coming along great. So it's the discipline like we all have for the type of work that we do, and it's applying it in your 5 to 9 job, as it's called.
Mm-hmm.
Yeah. Do you find that your artwork when you're drawing is it stressful, or is it the opposite where it's second nature and it's kind of your meditation and it allows you to escape from all other aspects of life?
Yeah, it's very meditative, and and now today with Pandora and Spotify, you just put music on and it's just let it go, and you can be there for hours doing that. But there's some basic skills in drawing that you apply in the morning when you go to work. For example, if you've got a template on the areola and you're going to cut a circle. Most people, when they put their knife on it, they're watching where the knife goes, but that's not the way you should do it. Your eye should be ahead of where your knife is, and you're not even looking at your knife, and you're just following the template around with your eye. And perfect circle. Yeah, I mean, yes, you have the template, but it's easy, and that's what it's like. It's like in other things like race car driving, when you don't look where you are, you look where you're going, and it's the same thing with surgery, and these are just rudimentary skills that you get in art as well, that I'm doing at night.
So one of the questions that I always enjoy asking our guests is, thinking back on you've kind of seen a lot of the whole field of plastic surgery, from reconstruction to cosmetic, private practice, academics. Even outside of plastic surgery, thinking back, is there any regret that you had in your career?
Well, Saïd, I've been very lucky, and things have gone exactly according to plan. So, do I regret spending, still working 12 hours a day? No, I don't think so. I think what I would say to myself at 30 is, don't worry. We spend a lot of time worrying about stuff, most of it, which never happens, as Tom Petty said. But, if you got your mind in it 12 hours a day, either if it's working or thinking about it, and you consistently apply yourself, things are going to work out, So I would say, don't worry, Chip, but you got the other part of it is, if you want to be successful, the phrase that I've come across is monomania is a prerequisite for success. And that's true. It's got to be total focus, all the time. It's harder because I think, some of the younger generations, you always hear of work-life balance. There's no such thing if you want to succeed at the highest level. I mean, I just don't think that's possible. So you have to ask yourself, what sort of commitment do you want to make to your work? Are you all in, or, you mostly in, and the result's going to be what you want it to be. So I think looking back, I don't have any regrets. Maybe this case or that case, but I've pretty much done every operation I've wanted to do. When I was a general surgeon, I wanted to do a Whipple. That was like it, and I did one. And you do free flap mandibles, you've done that. And I haven't done a face transplant. I'm not sure I'd want to, but I feel like I've done everything that a surgeon could possibly want to do. It's like a soldier who wants to go to war, and you've been there and you've done everything. And okay, it's not that you're done with it, but you just feel content with the road you've gone down. And from that point of view, I can't say I have a single regret.
Yeah, no, it's nice to hear that. And it's especially like the advice you would give your 30-year-old self. But so what does a typical week for you now look like? Like, what would you say the amount of sleep that you get, when your day starts, when your day finishes, how many days a week you work? What does it week look like?
Yeah, Saïd, today the whole thing's about what is it? Functional medicine, longevity medicine. So, I used to sleep 5 hours a night like the rest of you guys, and that's a bad idea. So, I try to get 8 hours of sleep. It's like, oh, wow, what's this? So I've never done that before. So that's pretty good. But that doesn't mean I don't get up at 5:30. I'm in the office by 6:30. We're starting surgery at 7:30. I still operate 4 days a week. On Mondays, I see my patients because I've tried every pattern, and what I've come up with is off the weekend, it's best to cruise into office hours, you kind of ease into it, get it out of the way, and the rest of the week is surgery. I've done it every which way. That works for me. Mm-hmm. So on Monday, I'll see, 40, 45 patients. And then I'll go swimming, see my wife for dinner, go in an art studio, draw the rest of the night, go to bed, get up the next day, pretty much do the same thing. So Tuesday, Wednesday, Thursday, Friday are surgery. I try to cut it a little shorter on Friday. We travel out of the city on Friday, and the traffic is horrible. But so I'll do like a 5-hour case on a Friday, or 4.5 or something. So I get out midday, and then on the weekends I'm drawing. I'm doing my homework, the things that Rod Rourke has me doing for the journal, and other such things, or getting talks ready for meetings like Baker Gordon. Although I don't do that as much as I used to. So I do that on the weekends. So the weekends, you start a Friday night, and you got a list. You got your notepad, and you got your list of 20 things to do for the weekend, and you just go through that. And before you know it, Monday morning rolls around again.
Would you say that it's always the people I feel like who are in academics per se, or tied to an institution like Memorial Sloan Kettering, they have this view of private practice. Some people thinking that, life's easier when you get into private practice, but there's this whole other element of difficulty, running your own practice. It's a business. What have you learned since doing that? Like, is life isn't easier, I bet.
Well, no, it's not. I mean, the pro is that you're in charge, and you want a new copy machine. You don't have to ask an administrator for it. You just go buy it. But the cons are that nobody teaches you this stuff, so you got to learn it yourself. And when you open an office, all of a sudden you got to be an HR expert too. You got to hire people. And if you hire the wrong people, you got just one person who's not perfect, the whole thing doesn't run right. So it's lesson after lesson, and you have to learn them more than once. Running an office is one of the most stressful things. The OR stress is fine compared to the office stress and the things that happen. You're end of the day, as we're trained, as surgeons, more so than maybe anybody else but a pilot, you're ultimately responsible for everything and accountable for everything. So whatever happens in your office, it's yours to deal with. So in many ways, the academic situation is much more comfortable, even though it's irritating because you have administrators and people keeping you from doing things that you want to do to be more productive. So it's 6 of one, half a dozen of the other. I've done them both. I find there, the advantages, disadvantages to both. I'm glad I'm doing what I'm doing now, but it's not easy. I even today, not just today, but today in general, I'm the first one in the morning and the last one to leave at night. And I've been doing this for decades.
Andrew that.
Yeah, you tell them. So but it's okay. I'm lucky that I don't have a lot of outside things pulling at me. My wife is, she's fully employed and busy as I am, so it makes it easier. Not everybody has that set up, so but that makes it easier.
Mm-hmm.
Yeah. So one of my favorite things, quotes from one of our previous guests, Dr. Nahai, said that academics is a state of mind, and that's how he referred to aesthetics. Because we always like to break up, are you in aesthetics or are you in academics, where it's just how you see it, and it's very technical, and I see aesthetics just as academic. But my question is, it seems like a lot of residency programs, back in when you were training, like you said, you'd had 50 rhinoplasties. They kind of went away from it. And then now I think it's kind of swinging back the other way again, because we have, at Penn at least, we have a chief clinic. A lot of our residents are trying to get their cosmetic reps up. But my question is, what do you think is on the horizon for aesthetics? Is there a bigger role for it in academia? What do you think?
I think that institutions are frankly not very interested in aesthetic surgery. It's baffling because it's a fee for service thing. There's no insurance. You'd think they'd be all over it, but it's still viewed with an element of disdain by academia. Which is sad, because maybe just for us plastic surgeons, because you look at the ENT programs, they have mobilized to the point where plastic surgeons may not be doing facelifts and rhinoplasties in the future because they've taken it over. So in that instance, you have a specialty that is maybe not that lucrative, and people don't want to just do what regular ENT folks do, and so they've mobilized and they've enabled their residents to be successful in aesthetic surgery, and we're getting killed. I mean, you can't call a facelift a SMAS lift anymore. If you don't call it deep plane, patient walks out the door. You don't do deep plane, and we all know that's semantics and nonsense. But to answer your question, I don't have high hopes for institutions to embrace aesthetic surgery. I think aesthetic surgery is all going to happen on the outside. We have our journal, which is still committed, and we have the aesthetic surgery journal, which is 100% committed. So it will survive and do well. But I don't think we're ever going to get a lot of institutional support. Now, I think the training programs in aesthetic surgery are not as good as they need to be for our young residents to come out and feel confident doing their first facelift by themselves. I worry about that.
Yeah. So my follow-up question, which was going to be, if you're a resident who wants to pursue aesthetics, what what would your advice be to be the best aesthetic surgeon they can be? I'm guessing it's going to be you must do a aesthetic fellowship after residency.
Yeah, that's critical. But, the problem is there aren't a lot of good ones around, and they're not diverse. They're either single practitioner fellowships by and large. Atlanta still has one, and there's some others, but I don't think you certainly can't do without it, because you have to have additional training that focuses on aesthetic surgery due to I think the inherent weaknesses in our regular programs. But I think like all such things, you want to get in the best program you can. So you want to go train with Rod Rourke, or someone like that, or Brad Calabrese for breast. So fellowship is essential. There's no question about it. Where you go after that is a little bit more challenging.
Well, I've really enjoyed this interview so far. I've learned a lot, and I've told Hank this before. Some of my closest mentors are, I've as many mentors as I have in the field of aesthetic surgery as I do in academia, reconstructive surgery, and however you want to subdivide it. But we do this kind of rapid segment at the end where we ask you a few questions that we've asked other guests before in our podcast. One special one for you is, what's your favorite piece of art or artist?
Well, it might be a little esoteric. For me, if the charcoal drawings that I do, the guy who started that was a guy named Chuck Close back in the 70s. And his first portraits were these like 12-foot head portraits that were airbrushed in black and white. And that by far just knocks me down every time I see one of those in the museum. But as far as painters, that's black and white. And painters, the color, the element of color as well as form, the brush strokes, that is by far to me the most challenging art form, traditional art form. So, a guy like Winslow Homer, the waves in the water, I could look at that all day long too. That's amazing. The big icons, the Picassos and the Rembrandts, yeah, but there are special things that I like. There's a guy named Wayne Thiebaud who's still around, he's a pop artist, and he painted, it sounds mundane, food, but it was like a piece of cake. When the colors, the texture, it just kind of blew you away. So that comes to mind, top of mind, but there are so many others.
What's your favorite operation now?
I can tell you what my least favorite are.
Yeah, I would.
I am super lucky that I have still a very diverse practice. One of the other issues nowadays is that I don't know if it's just that there's so many plastic surgeons, or because of how plastic surgeons have to make their name on social media, that everybody starts to super subspecialize. And what's not good about that is that the beauty of plastic surgery is you can morph your practice. And, we do head to toe. You don't have to do the same thing your whole career. So if you're going to be the abdominoplasty guy, okay, when you're 35, that's great. When you're 55, you're not going to like it, and you got no place to go. So, as a side message, I would say to our young plastic surgeons, don't pigeonhole yourself. Try to do everything as long as you can. But getting back to your question, what don't I like? I don't like liposuction. And listen, there are masters like Alfredo Hoyos, Simeon Wall, they're awesome. But for me, I don't like it for two reasons. It's very labor intensive. You get a little further down the road, these things matter. But also, I don't see cause and effect as much as I do in rhinoplasty or something else, because patients are supine, or they're on their back, whatever. And you're doing something and you're figuring it out, but you know what? You don't really see what you have until 6 weeks later. And I don't like that delayed gratification. I don't like the labor aspect of it. Breast reductions, I've done 1 million of them. And the problem is, the more I did, the longer it took me, because you start to see nuances. You say, that's not right. Or that areola is not round, and you just keep at it until you're done. You're there, 6 hours, and you got this, this fabulous result. but you can't keep doing it. So I don't like doing those anymore. But what do I like to do? I like all types of breast surgery. I like the primary augs, and I like the disasters, because I've gotten really good at fixing disasters and really confident. People send me stuff, and others look at it and go, "Oh my God!" And I say, "Yeah, I can fix that." And I know it's going to take a long time and probably twice as long as I budget, but end of day, that lady's going to look great when we get done with her. So I like doing those things. I find rhinoplasty is probably as everyone says, the most demanding operation in the world. And I go into those with just a little edge of trepidation, because that has to be perfect. You got a 16-year-old. You can't. Your bones, your upper laterals, your tip, everything has to be perfect. If you've got one little thing that's off, you see it, and they see it. It has to be perfect every time. So those are the most challenging to me today. Facelifts are great. Again, those are a bit of a slog in terms of time commitment. But, after a while, you understand the tissues, you understand how they move, you understand the shape, facial shaping, you understand what's going to happen with your SMAS when you do it this way or that way, with your platysma, how you get rid of bands, keep them away, how you say visually, going back to aesthetics, this lady needs an extra small chin implant. A lot of people miss that. It makes all the difference in the world. So, I love facelifts. Blefts, I love upper blefts. I don't like lower blefts. Lower blefts they're tedious, they're challenging. You got to transpose fat. You got to do a skin flap. Skin pinches aren't really any good. They don't get rid of the rhytids. So you got to do a skin flap sometimes. You got to resurface. They're very challenging, but you can get those great too. It's just you're working this. If most of it's done conjunctival, you're in this little tight space. You get a bleeder in there. It's no fun. So that's not one of my favorites either. But I must say, again, I enjoy the variety, because I'm not doing the same thing every day. So, okay, I got an abdominoplasty, I'm worn out. Okay, next day I got a face, I can sit down. So it's having the luxury of diversity that makes every day a good day.
Yeah. Well, thank you, Dr. Hidalgo. This has been amazing. We learned so much from you, and I know our audience is going to really enjoy it. I just have two last fun questions, and it is, what's your favorite surgical instrument, and do you listen to music in the OR, and if so, what do you listen to?
Well, my favorite surgical instrument is one that I like to in a tiny comparison to the fibula, where we came up with something that we needed, and that is submental retractor that I designed. It has wings, so that when you're deep down at the hyoid bone, the illumination cavity is huge. You can see everything. That's my favorite. But I couldn't go anywhere without a lighted retractor and a Bovie. That's what I use all the time, every day. So I would say those are probably my favorite. As far as music, I could talk for another hour, but we have music in the OR, as most do, and it's good for background. It's good for the staff. I let them pick. I listen to just about anything they put on. If it gets too much, I ask them to put a different channel on. But by and you know what? They know when I'm having a tough time, they'll put on some boomer rock and just let me ease into the problem, ease in and out of the problem. So it works that way too. But what I would say about music today, what I don't like about music today is that it's all about the lyrics and the singer. Nobody plays instruments anymore, and that's I miss that. Back in the 70s, 80s. Hotel California without the guitars was nothing. And same for Led Zeppelin or any of these other ones. So, I miss the instruments in the music of today, but there's a lot of catchy music that everyone seems to like and hum along to. So, yeah, we always have something on in the background.
Yeah. And it's nice for the staff to know when to adjust the music. So I like that.
Yeah.
Well, thank you so much. This is awesome.
Great.
Thank you for listening to The DIEP End, a plastic surgery podcast. If you've enjoyed today's conversation, please like, subscribe, and leave a rating on Apple Music or Spotify. Video from the podcast is available on Instagram and YouTube at the DIEP End Podcast. Join us again soon for more conversations with luminaries and experts in the world of surgery.